Okay, let's get started. Let's talk about the B assessment when we're looking after a trauma patient. And if you haven't already watched it, there's an A assessment on the CPD app by Lauren Weeks, which is absolutely brilliant as well. So obviously we're going to go through the series. You never know, there might be a C1 in July if you also want to get involved in that. So what are our objectives today? So we want to look at why is the B in the primary survey important? What pathology are we looking for? What's the actual evidence for the chest symptoms and signs that we've been taught to examine for? How can we efficiently identify the signs of chest injury? So clearly we don't want to miss anything important, but we haven't got ages to spend. And what are the common pitfalls resulting in missed injury? As we're going through, I'm going to tell you 3 pitfalls. So I want to see if you can remember those at the end of the presentation and make sure that they don't happen in your clinical practice. So most of the people online are paramedics, so we're going to mainly look at the pre-hospital management and the pre-hospital primary survey, but a lot of these findings will be relevant to the primary survey that we do in the emergency department. I've only got a short amount of time to speak, so we can't really go into talking about imaging and advanced treatment. The main focus today is to think about clinical examination and what we can expect to find. So let's just think now, why is the B in the primary survey important? So for me, we want to detect what important vessels or organs have you got adjacent to that could be injured. So if you have a first rib fracture up here, that can actually penetrate your subclavian vessels and cause significant internal exsanguination. And I've seen a number of patients who've died from that, from a relatively benign fracture that then obviously became intravascular injury. Ribs 1 to 3, you've got vessels and you've got nerves, the brachial plexus. Obviously, under your middle ribs, you've got lungs and you've got the heart. And then the lower ribs, you've got the liver on the right and the spleen on the left. So just remember, when we're talking about the chest, there's a bit of interaction, obviously, with all these different organs. We've also got other great vessels in the chest. We've got the esophagus, we've got the diaphragm. These can also all be injured, although much harder to diagnose in clinical examination. So moving on then to assessment of breathing. And on the left is how I was taught to do it in medical school a very long time ago. And on the right is how I was taught to do it when I was starting my pre-hospital career, which is actually also a long time ago now. Interesting to know what you guys obviously use. I'm going to obviously pick this apart a bit and we're going to go through each of the things. I think the 12, so the idea that you examine the neck as well as the chest is really interesting. I think that's become quite ingrained in practice. So the idea is that you look for tracheal deviation, you look for inspect any wounds on the neck, you feel for surgical emphysema, you feel for laryngeal crepitus, you look at whether or not the neck veins are distended, and then the E is variable depending on who's written the mnemonic. And I think this is interesting because the pickup rate for this is actually really low. And I'll talk through some of the issues with it in the future, but I can see that JR Calc are still recommending that assessment is being done for paramedics. So warning, I'm going to tell you how I do my B primary survey. If you're in an exam, please don't say, oh, I watched a webinar and Caroline Leech said percussion's a load of rubbish, so I'm not going to do it. Do what you need to do to pass your exams, understand the limitations, and obviously then adapt your clinical practice. But obviously if your oxygen levels are below 95, then you might need to titrate. And then people talk about splinting the chest. Well, I always ask patients to hold their chest if they're going over a bump, or if they want to cough or they want to move, hold onto their chest with a rolled up towel, and that obviously helps them. And our patients may be immobilised on a scoop, we might not have an option, but if we've cleared the spine, then transport in a position of comfort, which for people with chest injuries normally sat up, they're going to get much better respiration like that. So moving on then to pneumothorax and what are the clinical signs I would expect you to find. And of course, if it's small, you might find nothing at all. If it's a bit larger, then you might obviously notice an increase in the respiratory rate. When you ask them to take a deep breath in, they will stop. They will catch them on the affected side, so you could localise that. When you look, someone with a simple pneumothorax has no obvious clinical signs on inspection, but on palpation you might find some surgical emphysema. Percussion note, initially it'll be normal. If you're fancy, it'll be a hyperresonant. I don't think we're that great at it, and as I've said, I'm not a fan. And auscultation, as that pneumothorax gets bigger, you will start to hear reduced air entry compared to the other side. Sats are normally normal, and even in patients with massive, big pneumothorax, if they're young and they've got no underlying lung injury, they've still got normal Sats. So you can actually, they can compensate really, really well. Or of course, they might be reduced. And as we've said, patients with coexisting lung disease like COPD or any other sort of chronic lung disease, they're obviously not going to cope well with any of these things. I'm not going to talk in detail about ultrasound, but just to say I think there is a role for it in the trauma primary survey. And for breathing, it is really helpful to look for pneumothorax. If you haven't done so already, on the CPD app, there is an ultrasound webinar by a guy called Chris Yap. So if you're interested in that, it would be worth looking at what he says about this. And just to talk about the treatment for pneumothorax, so in the old days, every pneumothorax that we diagnose clinically, we would put a chest drain in. This is a CT scan. We're looking from the patient's feet up, so they have a right hypovolemic. So very subtle signs initially, but obviously as that gets bigger, then they're going to show more signs. So if you've got a massive haemothorax, you've got a big haemothorax, they're definitely showing signs of shock. So the respiratory rate will be increased, they'll be tachycardic, they'll be hypotensive. Inspection, if it's really big haemothorax, that lung's not going to move much on that side. And when you listen, then you should have reduced breath sounds. Your Sats may be reduced because there's obviously no air moving, or they might not be picking up because your patient's so shocked. So really, the massive haemothorax is kind of like a C condition, isn't it? So it's oxygen, definitely, IV access and TXA, fluid resuscitation, so either crystalloid or blood products, depending on what you carry, and get this patient to definitive care as soon as possible. They need hemorrhage control, whether that's from interventional radiology or in theatre. And also if they're on anticoagulation, they might need reversal of that very quickly as well. So the problem, as I said, is that things don't present like beautifully. And you could have a patient who has a tension pneumothorax and a haemothorax at the same time. So you've got all those signs blended together. And so people often say to me, well, what if you've got a massive haemothorax? And then you're like, is that a tension? And then should I decompress that? Well, the answer is if you can't exclude a tension and your patient has respiratory distress and they've got reduced air entry and they've got reduced Sats and they've got reduced blood pressure, then absolutely, you're just going to decompress that and you're going to take the hit. Ideally, we wouldn't drain a massive haemothorax in the pre-hospital setting. And the reason for that is that I don't believe in the tamponade effect, but I think you can dislodge a clot as the blood starts to flow out and then they start bleeding a bit more. And we don't have large stocks of blood products and we don't have a way of stopping the bleeding. And that's what's really important for those patients to get them to hospital. And then finally, cardiac tamponade. So there's your traditional signs. So really important to know that this is actually happening in a lot of blunt trauma patients. We're just not picking it up. But we notice that they've got pericardial fluid on CT scan. So blunt or trauma, the treatment, blunt surveys. There's no other injuries, but there's a lot of bruising on the left chest wall, and this patient is on a Pixaban, a DOAC for atrial fibrillation. He's also tender over the left chest wall. There is reduced air entry on the left-hand side. There are the observations. Have a think, what are your top 3 injuries for this patient? So I'm thinking rib fractures, obviously. I'm wondering if the patient's got a haemothorax. I'm thinking that blood pressure is a little bit rubbish for someone who's 68. Sats are a little bit low. Or actually, is it that they've just got a bruise and they're just really drunk and otherwise they're okay? We don't know. Okay, so this patient, for me, he's probably going to get spinal immobilisation because he's very drunk. He might not be able to clear the spine. You're going to give some tranexamic acid because he's obviously bleeding out into his chest wall if nowhere else. You're going to give some decent analgesia, even though you've got that blood pressure and even though he's drunk. If he is in pain and he's not breathing properly, he needs some analgesia. And probably when this patient gets to the hospital, he is going to have a whole body CT scan because of his age and because of the mechanism, and we'll see exactly what's going on. So that is the end of my talk. I think we've got about 10 minutes for questions. I can see there's quite a lot